South Dakota. Welcome, welcome, welcome. Sorry that I'm not there in person. I wish probably more than you wish I was there. I wish I was there. We haven't done any travel or been locked down since March. And so I miss hanging out with folks like you. But a little bit of the reason we're locked down is exactly what I want to talk about tonight. And that is the fact that we were all, I think, probably caught off guard by this pandemic. And if you think we weren't, I'm going to go ahead and call you out and call you a liar right now, because I think that we'd all done some training and we'd all talked about the pandemic and we'd all thought about the pandemic, but I don't think we really knew about the pandemic. So I'm hoping to spend the next little bit of time with you on the pandemic, and not just about coronavirus, but what we can do in the future to get more ready and better ready for EMS and emergency services as we deal with pandemics. So just a little bit of past practices and kind of where we were before this. You know, I think we all bought personal protective equipment, but I'd ask you how many of you really used it. I can tell you, based on talking to local folks here in northern Idaho, I think everybody was really religious about wearing gloves on every call. I think everybody, we were pretty good about eye protection, but beyond eye protection and gloves, I'm not confident that we were really using PPE to its full effectiveness. And in fact, one of the anecdotal stories I've had from this whole pandemic is the fact that I was talking to a guy who's a chief operating officer at a large metropolitan hospital, and he said, "You wouldn't believe the amount of hand sanitizer and soap." He said, "We're ordering like 500% more than we used to be," which makes me think we weren't even washing our hands before the pandemic. So I think we were doing it. I think we all trained on it. We met the minimums. We all refreshed everybody once in a while, but that was really it. We didn't really get into training on pandemics, and we certainly utilized PPE in our training. I'll remember the first night of EMT classes, we hit BSI, scene safety. And, anytime then I walked in the room for the next 5 months, every night of EMT class, we said BSI, scene safety. But how many of us really practiced it going forward after that? We all had some equipment. I can tell you that we had an isopod for transporting Ebola patients when Ebola came out. We all got ready for that, but then it sat on a shelf and never got used. So we really never thought about that. We occasionally met our mark by meeting with the health districts and the hospitals once a year and said, well, if Ebola ever happens, yes, we're still the agency you'd call to transport it. And so we had a lot of talk and very little action after that. So this has really brought up the fact that now we've had a lot of action and have had little time to talk since March. If you look at the past pandemics, certainly not a lot of news going forward. And so this is just a slide that I found, or a graphic that I found talking about past pandemics. And when you talk about the number of people that have been affected, I mean, you look at the smallpox, 300 million people. Well, that's the population of the United States. And right now we're sitting at roughly about 3 million people in the United States that have been affected by coronavirus, maybe a little bit more. And so when you think about past pandemics and you think about, we just didn't live in an age, when any of those ones you see on the screen happened, you just didn't see anything. We didn't have social media. We didn't have a 24-hour news cycle. We didn't have medical degrees given by Facebook and Instagram as we do now. I've never seen so many experts. And when you dig into who the experts are, you figure out that he was selling cars at the used car lot earlier in the day. And now he's an expert on pandemics and COVID-19. So I think more than anything, this graphic just illustrates that it's not something even though we've had pandemics, and we've certainly had a lot of pandemics, it's not something we thought of at a great length prior to. So where was COVID-19? And I love the picture on the bottom because that was one of the first pictures I remember seeing from Wuhan, China, or Wuhan, China. The guy driving around on his little scooter, fogging the streets and spraying everything. And we worry about what indeed was or wasn't happening. But it was first discovered in Asia, actually back in 2019, which is actually how it got its name. So it's the corona, and the vid is the virus, and 2019 is the year it was discovered. So it does have lots of similarities to other outbreaks. And initially it was believed to be respiratory in nature. So, for the first gosh, 4 months, 3 months of treatment, all we paid attention to was the respiratory symptoms and the fact that we were treating a respiratory disease, and didn't realize some of the other systemic effects that it was having. And actually, if you look back to the initial treatment, the mortality was higher at that point in time because we weren't sure what we were dealing with. So we immediately rushed to put anybody with respiratory compromise on a ventilator, only to find out that actually the ventilator probably didn't help nearly as much as we thought it would. We believed that it entered in Seattle, which obviously hits close to home for me. I'm 295 miles from Seattle. So if you look at the Seattle airport and the number of flights they have to Asia on a daily basis, and then we have flights. We have at the time we had 19 flights a day from our airport to Seattle. So almost one an hour, except in the middle of the night. And so we really started thinking, oh my gosh, this is going to hit close to home. But we don't think we had any idea what was about to happen, or the gravity or the scope. I mean, I think even when we were talking in March about what was going to happen with COVID-19, and as the words COVID-19, or end of February, beginning of March, as you started thinking about what COVID-19 was going to do and where it was going to land, I don't think anybody would have imagined that it was now October and we would still be talking about it and still be dealing with new cases and learning about it. I think we all thought probably we would have it much more in hand by now. So when it began, I want to tell you, when I would be honest, this was crazy because it was really the last time I traveled. I was in Tampa at GEMS, at EMS Today, at the national conference. We had an NAEMT board meeting. We were staying for the conference, and boy, people started talking about it, and some of the vendors, started saying, "Man, we're getting some interesting PPE requests," and that was really the first week of March. And as the end of that week ran down, I traveled to South Carolina and spoke at their EMS Association conference. And what I found out was that really it hit while I was there. And so I went from freewheeling, free dealing, life was good. We all sat around in a room of 300 people and had dinner and hugged everybody as they left. And when I got to the airport that Sunday morning and flew out, by the time I got to the Atlanta airport, it was, oh my God. And, they were handing out masks and people were walking through the airport with masks. And my flight from Atlanta to Salt Lake City was probably one of the most eerie travel experiences I've ever had. And I traveled after September 11th. And I would say this is on a level deeper of scary to me than it was after 9/11's travel. And that's just because I think that we really, really buckled down and got way more worried than I thought at that time we probably should have. And in hindsight, I didn't wear a mask that day and I didn't get sick. But knowing what I know now, I'm not sure we'll ever go back the other way of not wearing masks on airplanes, or it certainly won't be for a long time. So it kind of all began there. And if you look at one of the very first responder deaths in the United States as a result of COVID was a chief officer from a fire department in Florida who had attended EMS Today. And so naturally somebody, was a carrier and infected people. But again, we walked around and ate dinner together and hugged each other. And it was an EMS conference like any other EMS conference. And so to see some of those people and now have talked to some of those people and realize that outside of our families and our local work groups and things, those are probably some of the last people any of us have seen in a social manner for now going on 6 months. So it was a very slow to start. And so in states like South Dakota and in states like Idaho, in rural states, it was really slow to start. Information was slow. We sat around for a long time and scratched our heads. However, we needed to do something and we just didn't know what to do. And so below the picture below is kind of our governor's, one of his first press conferences. And we, like you, have a good governor. And I think that it was interesting to see Governor Little's, he's a very confident guy, and I've sat in meetings with him numerous times, and to see him really scratching his head, wondering what we were going to do. And he brought in a group of us, you know, obviously one of my very first Zoom experiences was with the governor to say, okay, how do we do this? And so the picture he's showing there is flattening the curve back when we said, man, 15 days to flatten the curve. And well, we're 15 days times, you know, 20 now and haven't flattened the curve yet. So I think again, we needed to do something, but we didn't know what to do. So it was very concerning for all of us as we went. And we were just trying to develop or we sat around it and played a waiting game for a long time. In fact, my very first experience that I'll never forget, it was March 17th. And let me back up for a second. March 17th. And March 15th. It was the day the county commissioners declared a local disaster. And I'll tell you, it was really interesting because I was sitting at home. It was a Sunday morning. And in Idaho, by law, the sheriff is the incident commander of any declared disaster. And it's a antiquated law, and that's what we do. But he called me, and it was like 7 o'clock on a Sunday morning. He goes, "Get dressed. I need your help." And I thought, well, that's weird. The sheriff doesn't call me, and we're good friends. So I said, "Sure, whatever you need, Ben. I'm on the way." And we got there, and he goes, "We're declaring a disaster, and the commissioners have named you the co-incident commander with me because you're the health guy." And I went, "Ooh, I'm not the health guy. I'm the emergency health guy," which is a lot different than the health guy. And so for the next 8 weeks, 10 weeks, we ran the EOC and kept it open. And that first few weeks, we really didn't have a lot of information. So we did a lot of ramp up, and gosh, it was almost to April before we had our first confirmed case, and we were testing like crazy. So it was a very slow start in a waiting game. As I said, it was really interesting because Seattle was ground zero. And so we border Washington. And, you know, all joking aside, I realized that your political affiliation aside, there's been a lot of talk over the last 2 years about building a border wall. We had a real talk about figuring out a way to build a border wall because we knew that it was getting really bad in Washington. And that top left picture there is kind of an indication. That's the very first outbreak numbers that they were getting in Washington. So you can see those huge numbers in some of those counties in Washington. And as I said, we're only less than 300 miles from Seattle. And so we really, really, really got very concerned about it. And it was right next door. Again, we have all these flights to Seattle. So one of our first meetings was, holy crap, how many people are leaving Kootenai County, Idaho, driving to the Spokane airport and flying to Seattle to get to wherever they get to in the rest of the country? And how many of those people are bringing back the virus and not knowing it or transporting it? But I'll remember, you know, we did a press conference with our first positive case. And now in our county, we're up almost to 3,000 cases. Not quite, but soon. And I remember we made such a big deal out of our first press conference and managing the information. And we gave a press conference and we talked about one case and how we were going to do that one case and how we were going to contract trace them and do all these things. And now it's impossible to do those things. But back in that time, again, we were measuring cases in the single digits. And I'll never forget that. So the bottom picture is a picture actually of Life Care in Kirkland. And they were the first long-term nursing care center in the United States to really have an outbreak of COVID. And they ended up having 20 some patients that first week. However, Life Care is a national company. Well, guess what? We have a Life Care here. So we quickly got on the phone with them and started working with them and trying to figure out exactly what Life Care was going to do, because they were making world headlines from, you know, right over in the Seattle metropolitan area about how they were dealing with this situation not too far away. So that's a picture of our EOC on the first week. And part of the reason I put that in there is to show you that we weren't social distance. We weren't wearing masks. We weren't doing anything. Look at us all just sitting around. So you can see me over there typing on my computer at the head of the table. The bald guy's the sheriff, and everybody else is that's our support staff in the EOC. And they're all trying to figure out what the heck is going on and letting the sheriff and I kind of run the show and do our thing. And we declared a disaster. And we figured out quickly that this was going to become a local issue. And we figured out really quickly that, we weren't a hot spot, so we certainly weren't going to get supplies, and we weren't going to get certain things done, and we were going to be on our own, and that's okay. But we had to make sure that we figured it out. And so that's a great team of people right there. Emergency management people, county finance people, firefighters, police officers. Our PIO happened to be a former TV reporter who now works as a sergeant at the sheriff's office. And man, it was his first time ever being the PIO of an incident. And he quickly figured out that the whole way we were going to combat this, we deal with a lot with wildfires. We deal a lot with, weather events, severe weather, and we're all used to that stuff. We all said, give us a fire. We can see a fire. We can't see this. And that was very frustrating. So we sat around and did a lot of what do we do now? And what happened was eventually after that first couple of weeks of lull, it got real quick. And we were really, really trying to figure out, well, okay, what do we do next? How do we do it? What are we thinking? And how as a team can we continue to gel? So it began, and that was a real struggle for us. So we started by treating this just like Ebola. And what does everybody do when they're faced with a new problem? They go to their comfort zone. They want to immediately flow back to what they're used to. Not that Ebola was comfortable by any stretch of the imagination, but we started thinking about how we were going to treat this. And so that top picture is not a picture of us, but that's exactly what our Ebola protocol was. We would strip all the supplies out of an ambulance. We would visqueen the inside. We would, cover the cot, and then we'd put an isopod in. We had special crews designated in one department that was going to handle all of our Ebola transports. And so we just said, well, that's what we're going to do for COVID, because why wouldn't we do that for COVID? And we talked through it, but we never really practiced it. And again, I think once a year we got the isopod off the shelf, we dusted it off, we replaced the batteries, we told everybody it was still here. I think I'm pretty sure that the health district gave us the isopod. So I'm sure that once a year they came to the office and checked and make sure that our isopod was still there and still functioning, and we hadn't sold it on eBay for pennies on the dollar. But we'd never really gotten it out and practiced doing it like we should have. And we had unrealistic decon plans. I mean, so, with an Ebola patient, we were going to take that ambulance out of service because, of course, we knew when we'd have an Ebola patient, it was somebody who had traveled. It was somebody that had self-reported. We were going to have 4 hours to respond to them. There weren't going to be hundreds and thousands of patients. So we were really dialed into thinking that was going to be how we do this next outbreak. And what we quickly figured out is all of our plans were unrealistic. Our decon plans were unrealistic. We were not going to take an ambulance out of service for hours afterwards to decide that we needed to, that we were going to have to do that in order to decon or to get an ambulance back in service, because most of these patients were not going to be because we knew they had COVID. They were going to be because they had symptoms of COVID and we're calling 911 now. And so we felt like the hospitals were a lot more ready, but then they became too ready almost in the fact that they started shutting things down and didn't account for the fact that we were still out taking care of people with heart attacks and strokes and traumas. And I'm going to talk a little bit about the numbers and the decrease in call volumes that people have experienced, but now are not experiencing. I think it was just really easy to revert to the past and figure out in the past practices that was what was comfortable and that was what was easy, but not necessarily what was the best. And so at the end, we'll talk a lot about lessons we've learned and where we go from here. So quick, hurry up and wait. Again, I think we all got together, man. We met daily, had the medical directors plugged in. Since I was the healthcare IC, I was meeting with the hospital and they were plugged into our command system and meeting with the health district. It was a little bit interesting to see the health district in our location was a little bit standoffish about joining the command structure, which was mildly frustrating to us. I'm not sure really why that happened or how that happened or what really is. who knows, that'll all wash out in the end. But I think it was very difficult for us to see that they weren't as engaged as a group with us as we thought they should have been. So we kind of adopted the nothing to see here, kept moving in different directions. But again, we had the media waiting outside the door every morning, and we didn't get a positive case for a couple of weeks. And so we were really just kind of sitting around, we certainly weren't twiddling our thumbs as we were ordering PPE and getting things ready and trying to figure out what to do. But we didn't have things going on, which was frustrating to everybody. It was a struggle to get everybody ready and on the same page. I think the fire and EMS guys that respond to medical calls every day did an amazing job of quickly getting ready. But all of a sudden we were training, we have 30 some dispatchers that work in our 911 center. It was training them that it is important to ask whether people have traveled or whether people have fevers or some of the other things that we were really struggling with getting ready. PPE was another one. We got everybody focused, again, back to my very first slide, when we talk about the idea that people didn't use the amount of PPE we should have been using all the time. And so now we weren't ramped up for PPE. We certainly didn't have stockpiles of PPE and N95 masks and things laying around. We ordered a lot of gloves pretty early on, and we ordered a few masks, what we could get. But I mean, it was a struggle to figure out what level of PPE we should really do. And of course, coming from a fire-based EMS system, I mean, I had guys saying, well, maybe we should be in a level A hazmat suit and an SCBA, all the way to, we still had people not wanting to put on very simple PPE. And then we had to look at all of our partners, like law enforcement respond. We have a great relationship with law enforcement in our community. But they respond in a much different way than we do to medical calls. So they weren't wearing masks, and they all wear gloves. But when we all of a sudden said, man, if you're going to come to a CPR in progress, you got to have eye protection, you got to have a gown, you got to have gloves. And of course, where did they turn to for all that? Us. And we were already rationing PPE. So it was a little bit of a unique experience in the what should we do and how should we do the PPE range. Then we adapted medical protocols. We really started looking at what are we going to do? I mean, we really evaluated any respiratory procedure we were going to do. And so we did things like, should we just use an adjunct airway like a King tube or just whether we even did an oral airway, something very simple like that. Rather than trying to do an oral tracheal intubation where we were getting that close to the airway. We looked at anything that we were doing an aerosolized breathing treatment on, of whether or not we should really be doing those things in the ambulances in an enclosed environment, or whether or not, if the patient was stable, we should wait till they got to the hospital. So we had a lengthy talk, and obviously we had to involve our medical directors. We involved the ER, we involved the critical care docs at the hospital, because we obviously didn't want to do the wrong thing as we were doing this. So we back, and still nothing happened. I think I missed this point earlier, and it was on one of the screens, but I want to tell you, one of our very first cases in Kootenai County was one of our firefighters. And so when it's one of your firefighters and they are the central point, that's what I say when I said things got real quick, is one of the very first cases was one of our guys, and they got it through their mother-in-law, who traveled from, of all places, Washington, the state of Washington. I told you we should have built a wall, but we obviously didn't in time, and haven't still yet. But we continue to deal with that. And so that's when we knew we had to do these things of getting our own folks really protected, because this person had been in a station, and he was at a station with an engine and an ambulance. So he'd had, 5 guys living with him for the time that he had been exposed. So we were very much in that quick hurry up and wait attitude for quite a while. So then we had to get information overload. So the top picture is our press conference of where we announced the very first positive patient. So that's me and the sheriff and the chief medical officer from the hospital and the director of the Panhandle Health District, and our sign language interpreter. I want you to know we were very appropriate. Now, when you look back, that was at the end of March. When you look back, none of us had a mask. I don't think any of us even owned a mask at that point. So, we were just pumping out a lot of information. So you had incoming information, and we had to decide how we were going to filter that incoming information. We had to decide what was real information and what was fake news, because obviously people were going to us or looking to us as the experts to provide good and factual and real information. Although some of it was very tough to do, and some of it was really interesting in how we did that. And then we had to figure out what was pertinent information, because I think, as you can all relate, we had an amazing amount of information, but what really did our folks, the healthcare providers, the emergency crews, the first responders, what did they really need as information as it pertained to coronavirus and COVID-19 and our response to that? And then we dealt with the outgoing information. So again, it was a real mix of anybody that got paid to work this disaster. The PIO was the most underpaid and overworked person there, I can tell you. He deserves a Medal of Honor for just how he handled it. I would say 90% of what he did is filter comments and questions from the public and really get down to the part that it was determining what was pertinent and what wasn't pertinent. So really important stuff. And then again, we wanted to take, we had to look at how we were sharing information with our partners. So we met every day with the hospital. And in addition to the incident commanders meeting, the PIOs met every morning at 7:30 for 10 weeks. And because the hospital had their own PIO and the health district had a PIO, and then we had a PIO. And so they would meet every week. And it was really difficult because at first the health district would release information without telling us or letting us know anything. And so all of a sudden we'd get a call or we'd see their post on social media, and that got to be a real problem. And so managing this information and this information overload became one of the biggest tricks in the disaster. And it's interesting because any time you do an after action review after a disaster, and for those of you that are going to listen to me, well, you've already this is my last talk, although I'm doing it first, is when you see my talk about MCIs and getting EMS ready for a disaster. And for those of you that heard me speak last year about the Joplin tornado, you know that I'm passionate about the fact that one of the biggest problems in any disaster, one of the disasters of any disaster, is the lack of communication. Well, I can tell you this became communication in a totally new spectrum for any of us. Is we had no concept of how it could or couldn't go and what was going to happen. And so while we as first responders think in communication in terms of how did my radio work? Did I have all the right radio channels? Could law enforcement talk to fire? Could fire talk to EMS? Could EMS talk to the hospital? All of those things. This quickly became an information problem with how we received and how we put out information. So the other thing we did is become fast friends with everybody. We quickly, got together, and not that we weren't friends with some of these people already, but I can tell you the other EMS, so we have the largest EMS agency in the northern 10 counties of Idaho. So people kind of look to us as a resource, but I will also tell you that we look to them. I mean, if for some reason somebody wasn't seeing an increased call volume and we often traded equipment or looked at each other's policies and procedures. I certainly used my network outside of the state of Idaho and talked to people all over the country about resources and documents and information sharing and protocols and all those things that we had to do. Again, I feel very fortunate that we have a very solid relationship with the hospital, and we had built that over time. So we meet every other month with the hospital, if nothing else, to get together and have coffee and donuts and figure out, who's Zooming who. And we've been meeting for 5 years. And at the first few meetings, boy, we had big issues. I mean, big issues of not communicating, and us getting equipment from them and them getting equipment from us and fighting over it and doing silly things. And now our biggest concerns are whether or not we're going to have an EMS picnic this year because of COVID. So it's a great problem to have. But because of that, we'd really already had that relationship. But we got people that weren't used to talking to each other at the table together. For instance, the supply guy, we have a logistics officer for EMS, and the logistics person at the hospital got together twice a week and compared notes on where are you getting things, where are you getting things. Well, we've got a pallet of gloves, we'll trade you for a pallet of masks if you have masks. And it got really interesting really quickly for a while. And we did at one point, we talked about ventilator circuits. And another great example, we gave them our transport ventilators to use in their ICU because they were at one point thinking they were going to have to stand up more ICU beds. And so we gave them our transport ventilators because we really figured that we weren't going to be putting a lot of people on the vent in the field, and we certainly weren't going to be transporting critical patients to other facilities or bringing them into our facility because our facility was ramping up to be full of COVID. So just examples of that. We, again, I would say one area of lacking relationship was definitely public health. And I'm pleased to report that that relationship is better than it was. We talk to them all the time. We recognize and every state does it differently. In Idaho, all of the resources that we're getting, so like the strategic national stockpile and some of those resources were going through the public health districts in Idaho. So if you weren't friends with them and didn't have a relationship with them, that did not bode well for you. We again had to really work with the other first responders who weren't necessarily used to running sick patients and figure out and put protocols in place to protect them. And it almost became a quid pro quo relationship with a lot of these people. Definitely, you scratch my back this week, I'll scratch yours next week. And that was probably one of the success stories and the neat things that came out of that. Not that any pandemic is neat, but I think anybody wants some success stories and wants to know what really happened through the pandemic and how it happened and how it went. That's going to be one of our biggest success stories, is the already existing relationships and the relationships we built as a group with them. So, and so the next question obviously to ask is what happened to the patients? Decreased call volume. Our EMS call volume went down about 40%. The hospital ER call volume went down about 30%. So these are not, these are all statistics that I stole from other people. So the NAMT president, Matt Zavadsky, sent us all this cardiac arrest data from MedStar in Texas. And basically their hypothesis is that people waited, they damn sure didn't want to go to the hospital. That's where all these crazy sick COVID patients were. So they waited so long that their cardiac arrests went up significantly in those first few months. Even though their total volume went down, their cardiac arrests went up. And so that just kind of goes into the acuity. You can see the bottom picture there is of a survey done in over the entire state of Texas of how many EMS agencies, licensed EMS agencies, were somehow affected financially by COVID. And you can see that only 9% were not affected and 91% were. And then that's just kind of an ER volume time frame. And so we definitely saw a decreased call volume. And what we found was that no one was calling 911 for the nonsense stuff. We went from getting, the person with 3 months of back pain who decided at 3 a.m. now was as good a time as any to call 911 and go to the ER to be seen for their back pain. And what we figured out was now people are waiting until it's too late. So not only were you having a STEMI, you were teetering on the edge of cardiac arrest, and you may be too late to go directly to the cath lab because by the time we got you there, we'd be doing chest compressions. The data was ugly. I mean, like I said, the acuity went up. And I don't have it right in front of me, but as I remember, our obviously our respiratory and cardiac calls, our traumas went down initially, but our sick patients went up and the acuity went up. The one thing I will tell you is probably the advantage for our agency, I won't speak for everybody, but and this was again because we didn't have huge COVID numbers. Now, if you look at New York City and things like that, where they were dealing with only COVID and ran out of ambulances and every hospital was full, they had those huge outbreaks at first back in late April, early May. We never saw that. We did see that pause or that drop in call volume. That allowed for a pause. And what that pause did for us was allow us to regroup pretty quickly and figure out the new way we were going to do things. So, it did allow for better decontamination. It did allow for good training of our people. It did allow for, I think, good patient care. We weren't sliding patients on patient care because we got so busy that we were doing that. However, the pause didn't last forever. And so we're actually now back to, we set a record for calls in the month of August. And I'm not talking about COVID calls. I'm talking about regular calls. We had the busiest month of August we have ever experienced in our history. So we went from, a 40% decrease back to pre-COVID numbers plus. And the hospitals were hit as well. I don't know any hospital that didn't have financial losses, because what they were experiencing was the loss of all of their profit centers. I mean, if you look at the elective surgeries and the treatments that they do and things that all got put on pause, and it was not good for the patients. I mean, patients that were on chemotherapy weren't getting treatment. Patients that were needed elective surgery, but not unimportant elective surgery, weren't getting elective surgery done. And so the hospital saw an increase in acuity, but their finances were hit as well. I can tell you our local hospital was at one point losing $15 million a month. And that was losses, not a $15 million hit to their revenue stream. It was $15 million of loss a month. And probably most hospitals can take a month or two of loss and figure out a way to recover. That's not a stringent plan for very long, nor is it a successful plan. And I will tell you, one of the conversations we had locally is our hospital is also the regional tertiary care center. So as they were decreasing services to get ready for COVID, and other big tertiary care centers that are 40 miles away were doing the same thing, we quickly said, well, what the heck happens to our STEMI patients and our stroke patients and our trauma patients, and doing some of those things. So all very important, all very, all considerations. And we haven't necessarily seen that loss of acuity either. I think we're having, in fact, from May to August, we had the highest number of priority 1 traumas in a 4-month period we've ever had. So, I don't know if it's people, it was kind of release the hounds and people thought, okay, well, I'm out. Here's what we're going to do. But it was definitely interesting. So quarantine, let's talk a little bit about quarantining employees. We'd never done that before. So all of a sudden we have a guy pop positive. And initially, of course, we were quarantining anybody that had come in contact. So we had our guy pop positive, and now I've got the 6 other people at his station that I've got to quarantine. And so what do we do? Never had to quarantine people before. In fact, no one could decide whether the definition was isolate, quarantine. And I'm not sure which definition we're using today, because I think it still changes on a regular basis. So we had to decide what we were going to do. We started thinking about alternate ideas. One of the great things that NAEMT did was get Hilton and American Express to donate 1 million hotel room nights to members. And I mean, we certainly took advantage of that. So we ended up having that first month $22,000 in hotel bills by having to quarantine law enforcement officers and firefighters and EMS providers. Now that's all reimbursed through the CARES Act, but we also had to think about what we were going to do, because we needed to protect the rest of the staff and the families. So we couldn't just tell these people to head home. If they felt like they could head home and quarantine and be safe at home and isolate, and then we let them. But we also made it available that they could have their own hotel room and protect themselves that way. We explored some other ideas, and it was really interesting because at first we had like some church camps step up and say, well, obviously we're not going to have church camp this year because of COVID. So what do we do and how do we do it and what can we offer you? So we made some agreements, and then they said, well, that's cool, but if anybody gets positive, we don't want them here. And so we really had to look at how do we isolate you and truly isolate you. So really big challenges that we probably never thought that we would have a challenge in. I certainly never thought what it would be like to quarantine, you know, a shift of people or anything. And I don't honestly know, to date, we've probably had a total of 20 or 25 people in quarantine from our department. And now we're to the point we don't follow the 14-day. We keep pretty well up on the CDC guidelines, and we allow our company physician to make some of those decisions for us. Some of it is whether or not you're symptomatic. Some of it is to what level of exposure you've had. But of course, initially, everybody was on lockdown. So all of the wives and spouses of the first responders were pretty much home at first. Well, now they're all back to doing what they're doing. In fact, we had a firefighter last week that tested positive, and he got it from his wife, who is a teacher. He wasn't exposed at work, but you know, we're now dealing with the fact that families are getting exposed and things. So really, you know, the number one goal was to protect staff and family, and but we had to develop plans. And I would tell you that in the future, you need to have some solid relationships. We have built a solid relationship with one of our hotels, and we would use them again. They offered us a special rate, and it worked really well. So we think that that's a great plan moving forward. So partners new and old, you know, it was really interesting. Again, we had to look at communal living as hotspots. So one of the first places we had to deal with was the jail. We have almost 400 inmates in our jail. And they worked really hard to get nonviolent offenders and people who were in serving a week sentence for their misdemeanor or whatever. We got the judges to pretty well take care of that very quickly. We looked at what the heck was going to happen though in the jail for the violent offenders. I was very impressed with the jails. They have their own healthcare staff in the jail, and they did a great job of testing people and isolating people and doing some things to better serve. So that was really, really pretty neat. The skilled nursing facilities and the assisted living facilities, we still are struggling to deal with them. I'll never forget one of our first cases in a skilled nursing facility, and they posted, before they let us know that their patient was positive, they posted it on Facebook. And why they would do that, I have no idea. The information that brought and the problems that brought were pretty incredible. So the skilled nursing facilities and assisted living facilities definitely have proved to be an informational challenge. And then now finding a couple that are willing to treat COVID patients. So what we found also was that patients that popped positive and needed to go to a hospital for a little bit, but then were released, had nowhere to go because they were being refused to come back to where they had been and where they were going. We also looked to our non-healthcare providers or our other healthcare providers that weren't hospitals in ways they could help us. You know, could they open up testing centers? Could they open up, could they do some treatment in nursing homes and things? And then we dealt with the schools coming back in. So like any state, we canceled all of our schools at the end of March, and no one went back to school. But now we've begun the process of going back to school. And so we've been working with all the schools. Actually, I'm a little shout out to Lake City High School there on the top. That's where my daughter's. She's on the student council and on the swim team, and they have a big swim meet tonight. So of course, as a dad, I'm not allowed to go, but we've been working with the schools very rigidly on plans to make sure that they follow the plan and have a plan, and kids still get education while being safe. And that's, you know, we have 20,000 children that are affected in our county by being in school. And so we've got to have a plan for that. So very interesting. Help, where do you get it? So that's a picture of our EOC and just a picture of the national stockpile. And then the bottom picture there is ambulances lined up through the EMS, through the national contract with AMR in New York City. So we quickly developed, opened up our EOC, and that really became the way that we requested um, supplies, especially PPE. We looked to mutual aid to figure out what was going to be available should we need it. We've been very fortunate that we never needed the mutual aid, but we had plans in place. We also had plans. We border, as I said, we border Spokane, and their county population is 600,000 to 700,000. So, naturally they had a plan of what they were going to do and what they needed help with, and we've had some of that. We looked to all of our partners. Again, the quid pro quo with some of our partners was pretty impressive. And well, I got masks this week, but you're going to get some next week. So let's trade. We did go through the states. Again, the state of Idaho, and I don't know, I don't want to speak to every state because each state handled it differently. The state of Idaho distributed their strategic national stockpile through the health districts, which worked well for us, but we pretty well eliminated and used the Idaho allotment of strategic national stockpile PPE pretty quickly. And since then, the state's gotten a little bit, but we've really relied on our local resources to get more of our supplies and things. And then obviously the federal government, we got a lot of information from the federal government, guidelines from the CDC, things like that. We did not go directly to the federal government for any aid or help. But I think it's important because this is the first, it's easy again when you can see it. If it's a wildfire, it's not really hard to call and say, we've got a big wildfire, we need help, what can you do? And people go, well, we can send you a brush truck or a tender or an engine or aircraft or whatever it is. It's a lot harder to say, we know we need help, but we don't know what type of help we need. We don't know where to get the help. And we're just kind of throwing our arms up at the wall, up in the air and screaming for help, or throwing something at the wall and seeing what will stick. We're just not sure what it is. So that became a big problem and still is a challenge today, I would say. So we developed a catastrophic plan too, and we're lucky we didn't need it. We had a plan of not going to 911 calls or triaging our 911 calls, that we weren't going to go to alpha level calls at all. And again, our 911 system never got so overwhelmed that we didn't or couldn't do that. But we definitely had a plan in place for how that was going to go or what was going to happen. And thank goodness we didn't have to go there. We also talked about treating in place unless really critical. Luckily, again, I don't think that became such a plan. Critical access hospitals became part of the plan, and they weren't happy about it because their plan was to ship anybody with COVID, no matter the symptom. If anybody was COVID positive, they were going to ship them to the tertiary care center. Well, what we quickly said is, if they don't have critical symptoms, we need to keep the tertiary care center for the critical patients. But you can't not treat patients. So in Idaho, we have 43 hospitals in the state of Idaho. Of that, 27 of them, I think 26 or 27 of them are critical access hospitals. So we have very few hospitals that have over 25 beds, but those ones that are tertiary care centers need to provide. So in our 5-county region up north, we have 1 tertiary care center and 4 critical access hospitals. Those critical access hospitals quickly became, whether they intended to or not, part of the plan. And then we had plans to develop a field hospital. And that was an interesting call. Our adjutant general called me one morning and, Chris, and I said, yes, sir. And, trying to be, he said, I understand you guys have the space and a plan for a critical access or for a field hospital. And I said, oh, we've had that discussion. He goes, good. Well, it'll be there at noon. So get ready. And we went, whoa, hey, wait a minute. That was kind of a shock. But we never unpacked it, but we had a 50-bed field hospital ready to go. And then our conversation with the field hospital was, are we going to treat regular patients and leave all the COVID patients for the hospital? Or are we going to make a COVID-only field hospital? And luckily, knock on wood, we never got there. I will say, probably one of the best exercises we went through as a whole result of this disaster was the idea of needing to form up a field hospital and what we were going to do if that was the case. So pretty interesting discussions to be a part of. So normal. And I had to be honest, I needed to add a little humor in here. So here are my funny memes of the day. So what is normal? I don't think, I would argue that we thought we were normal before, but I would see, I keep hearing the word the new normal, and I'm not so sure we shouldn't have had a little bit of the new normal before. Specifically going back to how we handle calls, and again looking at the PPE, shouldn't we have been wearing full face masks and goggles and gowns for when we were doing invasive respiratory procedures before? Probably so. Are we going to now? I would certainly think so. But we keep hearing the new normal. And then, so, 2019, we were maybe gearing up a little. In 2020, I don't need to describe to you, all of you professionals, what 2020 has been and what kind of year it's been for all of us. And the real challenge is, what the heck is 2021 going to look like? Because I think we were all pretty convinced at one point that, oh, this would last a while, and by the end of the year, we'd be back to normal. Well, none of us are together for a conference this weekend. So I don't know that, and I certainly don't know that the beginning of 2021 looks any better. So I'm not sure I agree with the new normal. I think there just is a normal, and I'm not sure we were ever normal before. In fact, most people would argue that because we all decided to be EMS providers, none of us are normal to begin with. So I think in the future, we have to look at calls and how we do calls. We need better screening. We need dispatch systems to pay attention to that. We need to flag potentially sick patients before we ever get there. Again, adding in questions about fever, travel, those sort of things. We've done that temporarily. I'm not sure that should be temporary. We need to increase the use of PPE more regularly. We need to look at crew integrity. One of the things that we did for our system is, because we're fire-based, so it really, every employee is an employee of everybody. We looked at, if an engine was first on scene and they made the first patient contact, to limit the rest of the patient contacts, we'd have that provider get off the engine and transport the patient in the back of the ambulance to try to limit those people, and whether or not, or limit exposure to the rest of the crew. So crew integrity has been a big thing. We've even gone across, so for instance, if it's a Coeur d'Alene fire ambulance, but it's one of our engines, even our engine crew will transport in a Coeur d'Alene ambulance, just so that we can try to minimize the exposure rate. We've looked at extra layers of clothing. So for two reasons. Number one, we've mandated that you can no longer wear boots in the stations. We bought everybody a pair of station shoes that aren't allowed to leave the station and go on calls. And then when you get back, you kick off your boots. And I'm not talking about turnout boots or bunker boots. I'm talking about just regular boots. And we bought everybody a pair of black tennis shoes, or then they had their choices. Some guys wore Crocs and different things, but that's what we're wearing around the stations, is not to expose. We bought everybody some coveralls, and they wear those on calls so that they can come back and again take those off in the apparatus bay and not bring those germs back in, because it doesn't make sense when you think, okay, well, we got to hurry up and get back and have dinner as a group. So we're all sitting there eating in the same clothes we just ran a potentially sick patient in. And then we're going to continue to evaluate protocols and where we go from here on protocols, because I think although we've reverted back to our original protocols and we figured out that, yes, intubating patients is very appropriate and doing it safely and things like that, we still have to think about how we're going to work on dispatch protocols and medical treatment protocols, and be thinking about those things in the future. I want to talk specifically again about PPE, and I want to talk about the levels you're using. So if you're not using N95 masks on calls, I got to say that the evidence is pretty overwhelming when you look at people that are masked. And if you've seen any of the cough studies or any of the spread and spray studies, it's really pretty important, and to wear a good mask. Now, when we're out in public, and we've allowed cloth masks in the stations, and when we're in public, and or simple surgical masks, but anybody that's with a patient's wearing an N95 mask. We mandated eye protection. Obviously, anybody that's doing a respiratory procedure is in a full gown, mask, gloves, eye protection. It's funny. because we've even seen an increase in our glove usage, which makes me wonder. I hope it's because everybody's wearing 2 pairs and not because people weren't wearing gloves beforehand. But the other piece I would encourage you to figure out how to do is stockpiling PPE and equipment. And this kind of goes in the old adage, when we had the drug shortages a couple of years ago and they really hit hard, we constantly asked ourselves the question, is expired epinephrine better than no epinephrine? And I, used the example of, well, if it was my kid in cardiac arrest, I'd want you to give him epinephrine, and if it was expired, maybe it wouldn't have 100% effect, but it'd have better effect than no epinephrine. And I got to be honest, to me, PPE is the same way. We had a great discussion of people saying, well, that mask is not in date, it's expired by 6 months. And I thought, well, we're getting quickly to the point of no masks or an expired mask, so I'll take my chance with an expired mask. So those are just things that you need to think about and work with your vendors, and then work with your crews to develop over the course. So most important asset we have is our people. We need to continue to figure out ways to protect our people. Quarantine is probably going to be an issue, whether you're dealing with it now, whether you're dealing with it in the future. Quarantine is an issue that you yourself are going to have and you're going to have to deal with. And so I would just tell you to have a plan and figure out how to do it. And it's interesting because Idaho is much like South Dakota, and that a large number of our providers are volunteers. So this isn't their only source of income, and they're coming back from a call or potentially being exposed to COVID and then having to go work at their regular job. And we're sensitive to that and think about that and trying to figure out ways how to do a better job of protecting the employees. Don't underestimate the mental health aspect. I mean, keep in mind, people have been pretty locked down now for 6 months. They're not doing their normal things. I thought I was going to win the husband of the year last year. I was taking my wife on a great vacation until they locked down. And so, we haven't gone anywhere for 6 months, just the two of us, and never ever underestimate that. And my point is not to have you feel sorry for me or my wife. My point is to say that we're not the only people that are thinking, God, it'd be great to get out of the house for the weekend. Keep in mind that you all have employees and providers that are thinking that same thing. And then the best thing, we were underprepared. And if anybody tells you they were totally prepared for this, they're a dang liar. So I would just tell you, this is probably not the first time in our careers we'll deal with this unless you're retiring next week. I think that you just can't argue with the fact that we've done a great job preparing for severe weather. We've done a great job preparing for terrorist attacks. We've done a great job preparing for man-made disasters. And now we're going to have to prepare again for pandemic disasters. I want to kind of start winding this down, but I want to talk about spraying and cleaning. And this is not a plug for if any of you recognize the brand of that device. I just look at that because that's what we have. So I stole some pictures and looked at it. But I would tell you, cleaning has become more important than ever, and we should have been doing a better job of this all along, but it protects the patient, it protects you. We bought foggers and sprayers, so we're really decontaminating the ambulances. I would tell you, several ambulance manufacturers and fire truck manufacturers are having built-in, you can see the lower picture there is actually a built-in way so that you can actually spray down the compartments of the ambulances. And so I think that's going to be, I would tell you that as you're speccing new vehicles and looking at new vehicles, man, figuring out good ways and having good ways to decontaminate, that is going to have to be factored into the design of a new vehicle. And I'd want all of you to be paying attention to that piece. Again, station life, you got to decon the station. We've really limited public and visitor access. Again, I already talked about the clothing and shoes. We've locked down all the entrances to one entrance. You can leave out of any door, but you can only come in one door. When we work a 48 hours on, 96 hours off. When you come in for your 48 hours, you come in through one entrance, you still do a temperature check, you sign in, and that's the only entrance in, and we're controlling that. You got to look at how you supply the stations and supplies that you probably, again, I never thought, we just bought 180 gallons of hand sanitizer so that every place in the station, bathrooms, kitchen, bedrooms, we have hand sanitizer in all those places, and looking at how we handle the stations from here on out. What are we doing with regular duty? How do we do training, and how do we get people together? You know, I can't imagine, the picture on the top right is everybody sitting there taking a class in an EMS academy. Those days, if you can't socially distance and do it properly and be thinking about those things, I think it's really important to be doing that. Meetings and PR. It's been interesting because we've done virtual fire station tours and things like that, and we do virtual meetings, and we're coming to you live, not live, but sort of live via Zoom this week for this education event. But for those of you that didn't have a strong virtual platform before, invest in a strong virtual platform, because I think it's the wave of the future. And not that we don't need to figure out ways to get back to real life training, but it's important to figure that out. I'd tell you to all pay attention to the CARES Act. It's been an excellent resource for us to get reimbursed for expenses and then buy some extra things that we didn't maybe have enough of, or things. So everybody's always looking for the bigger, better, faster solution, anything. One of the things we looked at from a fire department standpoint was definitely the ways we communicate. And so we invested in getting everybody their own SCBA face mask regulator, the part that screws in. Everybody already had their own mask, but we've gotten everybody their own regulator. We've gotten enough speaker mics now for our radios that no one has to share a speaker mic because you talk directly on it. We've got foggers for all the stations and sprayers for all the stations. We've stockpiled PPE. So those are just some examples. And as in any good disaster, you can't let a good disaster go to waste. So what's happening now? I know that we're going to get the COVID vaccine. We just don't know when. We think EMS may be a part of it. We know that flu season is coming. I would tell you they've predicted a nasty flu season. Definitely encourage. I know none of us can probably, well, some hospitals can do this. It's harder to do this in a civil service organization. You can't mandate your people get inoculated, but you can certainly encourage it. And we want to reduce risk as much as we can. So continue to get better and faster information. Again, information was one of the pieces that was really lagging. And get ready for the next pandemic, because it's coming. We don't know what it's going to be. We don't know how it's going to be, but we know it's going to be. So continue to get ready. So the takeaways, I think we've all talked about it. Again, better information, and you've got to manage the information that you have. You cannot underestimate the importance of PPE, A, wearing PPE, B, the number of and kind of PPE, and 3, having enough supplies to distribute and work with it. If you don't have partnerships, by God, you better get them, and you make sure you deal with it now. Make sure that in all of this, your employees are still a focus, because guess what? It doesn't matter all of these other things. So you can buy the best radios and the best ambulances and the best foggers and the best decontamination. Your employees are still your best resource that you have, and your most important resource. So if you're not taking care of your employees with planning and doing things, then by God, you got to get that ready to go and make them ready. And then again, just get ready. It's sad to think that we're dealing with this still, but we all admit we weren't ready, and so you shouldn't have that excuse 2 times in a row. So listen, guys, I just want to thank you. I can't wait to get back to South Dakota. I'm actually going to be there November 12th through the 15th doing a little pheasant hunting. I watched a video from your governor that said hunting is the ultimate social distancing. So I thought that I would give that a try, and I can't wait to get there. I'll be in Winter, South Dakota. So if you're in that area, I'd love to figure out a way to meet you and see you in person. Short of that, guys, I can't thank you enough for listening and paying attention. And I wish you all a very great rest of your conference. I wish you all a very safe and healthy rest of 2020, and look forward to getting back to the new normal in 2021. Guys, thank you so much and have a great day.